This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Ideggyogyaszati Szemle, published in 2026. It explores a potential new tool for our clinical toolkit, the FIB-4 index.
This is an interesting one, Ilara, because it bridges the gap between hepatology and acute neurosurgical intervention. The paper is titled Clinical Value of the FIB-4 Index in Predicting Decompressive Craniectomy After Mechanical Thrombectomy in Stroke. For those of us in the OR and the ICU, we are constantly looking for better ways to predict which patients are going to deteriorate after an intervention.
Exactly. To set the stage for our residents and students listening, we are talking about patients with large artery occlusion, or LAO. As we know, LAO often leads to malignant middle cerebral artery infarction. The current standard of care is mechanical thrombectomy, MT, to achieve reperfusion.
But here's the catch-22 we face every day. Successful reperfusion is the goal, but it can be a double-edged sword. The study highlights that reperfusion can result in ischemia-reperfusion injury. This leads to significant brain edema or even hemorrhagic transformation.
And that's where the neurosurgeon's role becomes critical. When that edema leads to intracranial hypertension, we have to consider a decompressive craniectomy, or DC. It's a life-saving procedure to prevent brain herniation, but the timing is everything. If we could predict who will need a DC right at the moment of admission, we could manage these patients much more proactively.
That brings us to the core of this paper, the FIB-4 index. Ilara, walk us through what this index actually is.
It's surprisingly simple, which is why it's so promising for emergency settings. The FIB-4 index is a non-invasive marker of liver fibrosis. It's calculated using 4 basic parameters that we almost always have on admission: the patient's age, aspartate aminotransferase, or ASAT, alanine aminotransferase, ALAT, and the platelet count.
It's a fascinating liver-brain axis connection. The study mentions that recent research suggests liver fibrosis may actually increase the risk of stroke. What I found particularly striking in the text is that this increased risk remains even after you adjust for conventional cardiovascular risk factors.
Right. So the researchers wanted to see if this FIB-4 index, specifically at the time of admission, could serve as a clinical predictor for the need for DC in patients with LAO, acute ischemic stroke, who are undergoing mechanical thrombectomy.
Let's dive deeper into why this matters for a neurosurgery resident on call. When you're evaluating a patient post-thrombectomy, you're looking at the scans, the NIHSS score, and the clinical exam. But those are often lagging indicators. If the FIB-4 index on admission, before the patient even goes to the angio suite, can flag a higher risk for malignant edema, that changes our vigilance level in the neuro-ICU.
Exactly. The study focuses on the index's ability to predict the transition from a standard MT case to one requiring life-saving surgical decompression. For the medical students listening, remember that the goal of the DC here is specifically to manage intracranial hypertension and prevent herniation when medical management fails.
And it's important to use the wording from the paper here. They are looking at the clinical utility of this tool. We aren't just looking at liver health for the sake of the liver. We are using it as a systemic marker for how the body might respond to a major cerebral ischemic event and the subsequent reperfusion.
It really highlights the systemic nature of stroke. It isn't just an isolated vascular event in the brain. The fact that ASAT, ALAT, and platelet counts, markers we see every day, can be aggregated into a score that predicts the need for a craniectomy is quite powerful.
It also emphasizes the danger of ischemia-reperfusion injury. We spend so much time focusing on getting the vessel open, but the paper reminds us that the injury following the return of blood flow is what often necessitates our surgical intervention.
So the takeaway for our listeners, keep an eye on the FIB-4 components: age, ASAT, ALAT, and platelets. While we wait for more prospective data, this study suggests that a high FIB-4 at admission is a significant red flag for future malignant middle cerebral artery infarction requiring surgery.
A great reminder that the best neurosurgical care often starts with a thorough look at the patient's baseline systemic health. That's all the time we have for today.
Thanks for joining us on the Neurosurgery Hub. We'll link the study in the show notes.
Until next time.